Welcome to the Global Robotic Assisted Surgery podcast. I'm Professor Hitendra Patel, and I'm welcoming you to the multiple episodes we have over the coming weeks and months. I hope you enjoy. Welcome to the Global Robotic Assisted Surgery podcast. Thank you for joining us for this exciting episode today. We have with us from India, the Apollo Proton Center in Chennai, which is Dr. Srivathsan Ramani. Thank you and good morning to you for joining us.
Good evening here, sir. Yeah.
Oh, apologies, it's the evening. I hope it's not too late. Well, thank you for joining us. Exciting times in the world of robotics, particularly in our field of robotic urology and robotic urological oncology, which I know you are the director of in your institution. So thank you for sharing a few moments of your time with us this evening then for you. Let's just get straight into it. We've had a nice little chat about you, but a lot of our listeners, they want to know how you got to the top, how you got there, how you actually made it as the director for robotic uro-oncology. It must have been really difficult on your journey, or it might have been really easy. I don't know. Why don't you just tell us a few minutes about how that went for you?
I wouldn't say top, but yes, to get to what you want to do is kind of one difficult, and second is always you don't know what you want to do at certain point of your time. I mean, you're still evolving, you're still learning, and so many factors also get into it. So my interest in surgery was stimulated during my undergraduate days in MBBS because of my surgical unit training and all those things. So I've always known that I want to be in the happening kind of field, which is surgery, which is always kind of exhilarating when you do something, this thing. Medicine, I wouldn't say it was boring, drab, but then most of the time it was like writing prescriptions, and maybe with the interventional procedures that happening recently with cardiology and gastroenterology, it's probably better nowadays. But 15 years back, especially in a government hospital in India, it used to be pretty boring, and it was like reading ECGs and trying to decipher things which were I couldn't see in the ECG as well. So it was like
just for our listeners, ECGs are not boring. They're a very important part of our medical lives. Yeah, just we don't particularly enjoy reading them, right? I think you're sort of
surgeons. Okay. So that kind of made surgery more attractive to us and as a field. And it also depends on your teachers, right? The way they teach and the way they promote their field is something. I mean, we are all promoters of our own field. I mean, it should make sure that anybody who watches us do something feel that, okay, I should also get into that kind of a thing. So that's what stimulated me into the surgical point. And actually, people were quite surprised that I did not choose an end specialty like an orthopedics or this thing when I chose general surgery. But then I went to New Delhi to do in an institution to do a general surgical training. That's when it really opened up my viewpoint, and I was able to interact with great surgeons who really led me towards a path towards urology. So one of my bosses,
which institution were you in Delhi? Sorry,
Maulana Azad Medical College in New Delhi, MAMC.
Okay.
It's called. Yeah.
Okay.
So my prof was a lovely gentleman called RCM Kasa.
Yeah.
He was trained in the Weill Cornell University under Dr. Mark Goldstein, who was one of the.
Yes, I know.
Yeah. So he was trained under him. So he instilled that interest in urology per se when I was a general surgery resident. And that's how it all started. And we used to do most of our urology in my institution, my unit. So that's kind of stuck on to me. I mean, I was well versed in endourology by the time I finished my general surgical residency itself.
Wow, amazing.
We didn't have a urology program in that hospital. So it's kind of fell upon us to take care of the urological load of that part of Delhi. So we used to take care of that, and that kind of stuck on to me. And I thought now that, I knew a little bit of urology, it's both useful to me as well as to this thing makes my training more easier as well. So why not take till the time I entered surgical residency, I was more into oncology and stuff like that. So by the time I finished my residency, I was turned towards urology, which is very exciting field because it's all using of technology. It's of endourological maneuvers, which is kind of exciting compared to the open surgical techniques as well, though laparoscopy was also on the mend at that point of time, but still endourological with the use of lasers and so many other factors. It was quite enticing. And my boss was also into andrological techniques. We used to do vasoepididostomy, which is like sewing 10-ethylene onto vas and epidermis and so forth. So it was kind of
you're
very
interested in all microsurgery,
microsurgical
miniature
techniques.
surgery, keyhole surgery, minimally invasive. So
It
actually,
was
you go into all the
everything put
delicate.
together. Urology was everything put
Sorry,
together.
I'm missing what you're saying. Say again.
It was urology was everything put together. You had laparoscopy, you had endoscopy, you had microsurgery. It was kind of mix of every kind of field that you would wish as a surgeon. So that kind of put me onto the path to urology as well. So that's when I finished my residency, I then joined All India Institute of Medical Sciences as a senior resident, which you usually do whilst you prepare for your entrance exam for your urological training and so forth. So there I was exposed to a varied variety of surgical cases, especially trauma. So that was the Apex Trauma Center in Delhi. So that also, improved my surgical caliber as towards open surgery, fast surgeries and all those things.
Yeah.
So, but still my mind was still towards urology, because I still felt it was still a cool and calm field. There was no hurrying. This trauma was really getting to my adrenaline rush as well, because you have to open and close like five minutes. You have to be inside the tummy of the patient, control the bleeding, pack, and then shift him to ICU. You lose a couple as well. So it was not. So then I realized that
it's too much excitement, right? In trauma
surgery. Excitement. Every time I used to hear an ambulance sirens, I used to get up like this. Oh my God, like patient is in. So that kind of was too stressful for me, and I'm not my cup of tea, I felt. That brought me back again to urology. I said, yes, that's it. Decided urology is the way to go forward. So that's, we have only two emergencies in the entire urological practice. One is retention, the other is torsion. So he decided, yes, urology is the way to go forward.
So once your life calmed down, what happened next?
I'm basically a very calm person, try to not to get stimulated and everything. So that suited me better, is what I felt to my personality as well. So that's when I went into my urological training in Chennai at Kilpauk Medical College, which was shared between two hospitals. And that's where I did my urological training for 3 years. At the end of urological training, again, you get confused as to how to go about whether to subspecialize or still continue as a general urologist, because as you know, in India, especially in Chennai, it's kind of like a very conservative, non-subspecialty based practice that everybody does. So you do a couple of stones, you do a couple of prostates, you do nephrectomies, you do everything, you do transplants and everything. But again, after I did a couple of years of private practice after my final residency with urology. And I was also along with the senior Dr. MGR is popularly called. He was my godfather as well. He used to guide me in my day-to-day practice and all those things. But I still felt something was missing, because oncology was not a big part of my practice. It was all stones, usual bread and butter of any urologist: stones, prostates, maybe a couple of tumors either here and there, and so forth. So something was missing from that. That's when I got an opportunity to do a observership in the UK, in London. So I came down. My wife is actually a nephrologist, so she also had an observership under the EREDT, this thing with Prof. In Royal London Hospital. So I wrote to them, and then Dr. Prasad Patki was one of the professors there at Royal London and Royal Free. So I got attached to him for around 6 months, stayed in London. And that's when I got introduced. I was already aware of the robotic technology, but I was not sure which part of subspecialty. I was looking into reconstruction. I was looking into endourology per se, complex stonework and everything, because I was doing a little bit of everything. So, but I was not sure which way to go forward and so forth. So, but when I visited London and I saw the robotic surgery being done in Royal Free, and the renal tumor unit that ran the entire East London's thing in Royal Free, that's quite impressed me. The tumor board, the multidisciplinary meeting, they used to discuss about 60 to 80 cases per day. for a single meeting. So these kind of thing and research impressed me a lot. So that's when I decided that, yes, I think uro-oncology is a field that requires real dedication and concentration that let me, subspecialty. Though I was still not aware whether India was the place to practice a subspecialty division per se. So I did. I then came back to India. Then I was selected for the what is called as a Vatikuti Fellowship, which is basically they select a few people. That time, Vatikuti was the one who was,
Just
selling.
for our listeners, Vatikuti is the institute in Detroit when they have a funding program, which Mendel Bandari is organized with Mani Menon. So I think we've heard that from our previous speakers as well. Vatikuti are doing good things abroad to try and help people develop robotic surgery. So sorry, please carry on. So you got a Vatikuti Fellowship and then?
Yeah, so I was selected for the Vatikuti Fellowship. As you rightly said, they help us young surgeons to develop into a subspecialty, to learn new things so that we can go to different parts of our country and do practice that as well. So I was selected at the Kokilaben Dhirubhai Ambani Hospital under Dr. T.B. Yuvaraja, who is my mentor in robotic uro-oncology as well. So I did that fellowship for a year, post that around 2018-19. That's when I finished my fellowship.
Yeah.
Then again, after finishing the fellowship, again, the question of, how to get back to your practice, how to go back to your city and then start your practice. But by the time there was an established robotic program at Apollo Main Hospitals at Greaves Road, which is the main Apollo, it's called in Chennai. So I connected with them, and I also connected with a surgeon, Dr. Raghavan at Chennai Apollo, who along with him, I do continue my work currently as well. So we both work together as a team. So I connected with him, and then I joined Apollo Main Hospital as a consultant. So I worked there for about a year. I helped them develop the program there. I introduced certain few things because there were about 3 or 4 surgeons there at Chennai, because that was the only center having the robotic technology. So there were 4 or 5 urological surgeons who are doing surgeries, each one in their own technique, each one in their own way.
Oh, just 1 second. Sorry. Just I was interested to know what did you bring that you learned from all your other fellowships? What did you bring to them that they didn't really do? That's interesting to know.
Yeah. So as I said, there were a couple, 3 or 4 surgeons who are there currently working in Apollo when I joined as an in charge of the robotic department, basically mainly for urology. So what I felt, many of them were not fellowship trained. They just learned on the go. Couple of them were fellowship trained, like Dr. Raghavan, who were already trained in the robotic and had a sense of doing certain ways and all. But what I found difficulty was in helping all the 5 surgeons, each one doing their own way was kind of difficult. So basically what I did basically like a checklist that these things will be done for this patient, like a prostate or a partial, what to do.
Okay, so you standardize
the steps so that there is no variation between, at least not in, maybe the surgical technique may differ inside this thing, but the approach and all those things.
That's fine though. You help standardize something that was not standardized. That's quite a common finding in many institutions around the world, and that people don't do things the same way. And we know that you have much safer surgery when you standardize surgery. You can predict outcomes for patients. I think that's all important. And so well done. You've actually found these things, put it together for them, and helped them. That's amazing. How did that feel? How did that feel? How did you feel about it?
Good. I am actually proud, and it's a thing because these were five or six surgeons who were completely not in interaction, and I then brought them together in a similar way, without them themselves realizing that they have all fallen into that kind of a standardized practice, which I'm actually very happy about, because it made training easier as well, because we do have residency in our
listen to me. I'm proud of you for actually, as a junior person in a senior department, changing their behavior. That is really difficult to do. Once people are stuck in their ways, how do you change them? So you're not only proud, you are very brave to have done that. A lot of courage.
True. It was little over the line, but then also we should appreciate that the senior people were, humble enough to accept my advices and took it, without any much issues, and said, okay, if you
Yeah,
say this is better, why not?
yeah,
That
very
was
good.
really amazing. And they are all still my friends, and they do call me whenever they are in trouble, and we do help each other out. So it's a kind of like a community thing. But still, in Chennai, the practice is generally not like that. It's kind of very competitive kind of a practice, which I'm totally against. I mean, you're all
So
working for
one
betterment.
again, just 1 second, just for the listeners, when a surgeon's in trouble and they're ringing another surgeon, I think what we're saying here is that they're seeing something that they've not seen before, might be a little bit more complicated, but the patient isn't actually in trouble. It's the surgeon's thinking that's in trouble. I've just got to make that clear. Sorry, please continue.
Yeah. So that's one thing. And there's also a point of economics in robotic surgery. Always in a developing country like India, we are always looking at the cost of penny, because the patient is bearing the entire cost for the robotic surgery, not the state. So that is always this thing. So we were always looking at methods and means in order to cut down the cost for the patient, and trying to utilizing certain techniques in order to prevent the cost from going up. For example, the use of the fourth arm, the use of certain techniques to give us some traction so that we can avoid using the extra arm, save some penny.
We'll come back to the costs and things in a minute. I'm more interested, as I said to you at the beginning, in your journey. So let's just fast forward now. So you're currently one of the few subspecialists, uro-oncologists in India, and you have a particular interest in prostate cancer. And as you told us before, you're actually interested in prostate awareness, and we should obviously name check Movember, this is Men's Health Month, which started in Australia, and we've all obviously all of us in Men's Health are happy to promote men's health, not just because we're men, because we look after a lot of men. So with prostate cancer being still the second biggest killer of men in India, I mean, that's amazing. I didn't know that the full detail. It still continues to be a problem, and yes, you're doing awareness. So I know this is a robotic assisted surgery podcast, but the disease is also important. So what made you go after prostate cancer out of all the things you could have done in your oncology? Why prostate cancer?
The first thing is that if you note any kind of patient who walks into our OPD with prostate cancer, many times you find that like 50% and more, that you find that patient is already metastasized, the prostate cancer is already spread.
Yeah.
And what could have been prevented by a simple blood test? I mean, we speak so much about self-breast examination. We speak so much about other cancers, which is important. I'm not saying no. But because of the varied nature and the lack of awareness of prostate cancer, we do miss simple things like including a PSA test. And that leads to possibly I'm not saying it would have prevented all the cancers, but at least would have picked up earlier cancer, or maybe a betterment in the quality of life for those patients. So I found it very distressing to find that most of the patients that I'm diagnosing, I'm not able to do anything from my point of view. I'm just going to hand it over to the medical oncologist or the radiation oncologist to do something to salvage a little bit of quality of life for the patient. So this kind of put us off as to the treatment part of it. I mean, we do get frustrated even while doing a great surgery. You may land up in issues later as well. But still, here you are at a situation where you are not even able to offer anything from a surgical point, leave alone the surgical point, but a good quality of life. I know there are controversies between radiation versus surgery and all those things, but even that we are not able to offer just because it has been a late diagnosis. And if you see the PSA testing in India, the cost of PSA testing is nothing nowadays. And even in India, it's quite cheap. So what you would probably spend on a single ticket in a movie hall, you can get a PSA test done. So that kind
education is your key point, right?
Yes.
Yeah. You're trying to obviously survey the population in a better way. And can I just say, I know we're talking about technology and robotics, but this point for me is so important. To find a patient that you can do nothing for apart from palliative is very sad for us as doctors, right? As us as human beings. So from a patient-centric perspective, it's dreadful. So can I just say thank you for doing that? You're actually making a difference, right? You're helping people that couldn't be helped before. No, that's amazing. Thank you for doing that. So you've shown courage, you've shown bravery, you've shown knowledge, you've shown humility, and you're doing a good thing. So there's nothing else left in your career. You're done, right?
No, I think it's all part of the career, right? If you're, I always say to my colleagues and juniors and everybody, when they see a patient, they see see it like a clinical detail. They see like, okay, this is the condition, this is the treatment. I would just say that don't bring, okay, guidelines is to guide us, but then you have to bring so many patient factors into it in order to formulate a plan for the patient. And you will only do to that patient what you would do to yourself or your relative. Only if you feel that, yes, this is what I would have done. For example, there was a survey in the urological conference for a 1 centimeter stone. Would you prefer an RARS or an ESWL? The urologists all voted for a ESWL.
Yeah.
Nobody said RARS.
Yeah.
Whereas you would do the RARS on a patient. That's not fair.
Yeah.
So I always think that if, for example, if I feel a robotic prostatectomy would not benefit a patient, I would not do that. And that's the way to go forward. And I know in UK, it's very much standardized. You have your protocols. You just, I've seen it in the renal board as well. You just get your grade, the stage, and you know what to do. But here, there is a part of economy, there is a part of finances, there is so many familial factors, there is confusion. They take 6 opinions from doctors. So there are extraneous pressures as well. One relative will say this, one WhatsApp message will say this. So can you believe that I've had a consultation with a patient for 6 times for 6 hours, just to tell him that, see, surgery may or may not help you. So, but he's still undecided. So these kind of things you have to go through. You have to this thing, and there is no point in getting impatient with the patient. He's named as a patient for a reason. So you have to be patient to him. You have to listen to him. You have to tell him that, yeah, I understand what you feel, but you have to take a call or you have to take a decision. I can give you the pros and cons.
That's fine. So that's your way you're practicing, and amazing. So you're clearly a balanced young man, doing a great job. But now we should move on now to we've talked about you and your journey and the people that have helped you, your professors, your mentors, your guiders, and in fact how you have also helped your mentors and guiders with some help that you standardized things for them. So I think one of the main conclusions is standardizing a process is always safer. So as part of safe surgery, standardization, stepwise approach. So we agree on that. So if we move on a little bit now into your specialty, so robotic assisted surgery in urology. Now, that was the #1 surgery that came out years ago, and it's now arrived in where you are, but it's obviously arrived around the world. There are lots of robots available as well. It's not just one, there are plenty. There are 8 different systems available clinically around the world. So people are using them, and the dilemma that patients have with having an operation versus not having one, well, surgeons in hospitals are now having a problem with which robot should we use, right? And where should we go with it? But we're not going to go there either, because all the systems are equally effective. We're sure about that. So it's a question of marketing, and we're not going to talk about marketing today. What I would like to know from you is, when you're doing pelvic surgery, you remember doing open surgery, 100%. Yes, how you trained. That's how I trained. And then we went to laparoscopic, and then we went to robotic. Can you just tell me a little bit about how you feel personally, your personal view? Okay, not a paper. You as a surgeon expert, how do you feel about doing open surgery on a patient from a surgeon perspective and a patient perspective versus robotic surgery, surgeon perspective, patient perspective? Just give me an idea of those combinations.
Right.
Comparisons.
So basically, the use of robotic surgery, I feel, is especially in the pelvic surgery. It's amazing. I mean, the advantage robotic surgery gives you over open surgery. I mean, I love open surgery. I love doing open surgery even now. I mean, the kind of feel of the tissue is what we all love and do. Yeah. So I love open surgery. But when you look at the patient's perfect perspective of an open surgery and the recovery period and the blood loss in pelvis, especially where your vision is most of the time blind and you're going to put your hand into it and do like this over the rectum, especially if you're doing a prostate surgery, you know that, that kind of a visual clue that you get in the robotic surgery is amazing. My experience with lap pelvic is not too much. I directly went on to the open to robotic, and reversely, I've come back to lap. And one thing I'll tell you that after doing robotic surgery, my lap skills have definitely improved because your understanding of the anatomy has become. I mean, I can do a pelvic lymph node dissection equally well with the laparoscopy as well, and I do a lot for my colleagues because they have other cancers or orthopedic cancer. They would like a melanoma. They want me to take out that pelvic nodes, and I'm the go-to person. And robotic technology for that will be a too costly anywhere. So I do pelvic lymph node dissections for them. And definitely my knowledge of anatomy, it's the best tool to learn anatomy. And that's what I keep telling my residents. If you want to learn pelvic anatomy, you have to see robotic surgery. It can't be more crystal clear.
So that's amazing you're saying that. So what I understood from what you said is that your robotic camera view, 3D view, actually is improving your knowledge of anatomy, but also it's improved your ability to do cheaper laparoscopic or keyhole surgery. That's an incredible statement.
Definitely.
So that's an amazing learning point. Yeah. Yeah. So your vote is you love feeling tissue with your hands, but the anatomy is much better with 3D view. Therefore, do you think you're doing a better job with 3D robotics compared to open surgery?
Definitely, yes.
When are you doing? When is it the opposite? But when is it the opposite? I'm interested. So when do you think open surgery is better than robotic for a better operation?
I would suggest probably. I'm not sure. Nephrectomy definitely better with robotic. Partial. Sometimes I feel maybe I would have done a better job in open, the suturing part of it, because sometimes you're always in a rush to take a robotic suture there. Other than that, there is. Do
you mean because of the ischemia time? You're talking about the clamping time, right?
Clamping
so
time.
With open surgery, you don't need to clamp always, do you? You can just.
Yeah, I can just hold that area. And then
well, let's go there. Let's go there. That's an interesting one, actually. You've reminded me. So, as a robotic partial nephrectomist, do you think that we are rushing operations because of the warm ischemia time versus open surgery where you don't even have to clamp and you can just hold it, you can squeeze and you got better.
Or you can ice it. Yeah.
Say again?
You can ice it. You can
do lots of things, but
the kidney, you can do lots of things.
But that's fine. But actually, we're just comparing like with like. So, double warm ischemic time in robotics versus warm ischemic time in open. So the feeling is, I mean, when would you not do a robotic partial nephrectomy? What kidney tumor position might you not do that, or would you do a total nephrectomy? When would that be?
Any large complex central tumors, I tend to offer open partial. Because it gives me though the magnification is great in robotics, the kind of the feel and the control over the kidney in open is unmatched still as well. Because once you unclamp and you see the bleed after the unclamping, it's quite unnerving. And if there is a condition where you may have to clamp it again, it's kind of distressing. And then, you have to take out the sutures and redo the entire inner layer again. So that's something which is, I wouldn't say technically difficult. Probably with more experience, I may become more, changed view in this pattern. But currently, with whatever experience I have had, I must have done about around 500 partials at least. So I feel sometimes, not in every case, not in a peripherally placed small tumor or even in a peripherally placed large tumor, I'm quite comfortable doing with the robotic technology. But when it comes to the central tumor and quite close to the tertiary branches or the secondary branches of the vessel, and sometimes I feel that maybe open may have been a little better, especially with regards to the warm ischemia time, where I'm not bothered about it that much. That's the only way.
So there's interesting comments because what we're basically both saying is that there are outlier cases, both with tumor position, But we could also say, and I would definitely say, there are outlier surgeons. So there are surgeons who would take on anything always robotically. And I always say robotics is a technology. It's a tool. It's an applicable tool for the right situation scenario. And I think you agree with me, right? And we would both be, the patient is patient-centric. So what's right for the patient? I think you've said that multiple times in this interview. So on that note, the doctor who's shown courage, bravery, standardized robotics in India at the Apollo centers. Amazing to talk to you. Thank you so much for joining us this evening from your busy schedule. I enjoyed speaking to you, and I hope we talk to you again. And so from the Global Robotics Assisted Surgery podcast, this is Professor Hitendra Patel. Thank you and good evening.
Thank you.